टाइमली चाहिए ना। Really? 8-5. Yeah. Good morning, Dr. Abhishek.
Yes, sir.
Good morning.
Sir.
Today we'll have a case presentation. Patient presenting with epigastric lump with the diagnosis of pseudocyst of pancreas. Our second year PGT, Dr. Onkar Nath, will present the case. And along with me, Dr. Abhishek Bhomik is a senior resident at MR Bangalore Hospital. And FNB, Dr. Abhishek Bhomik will be with us. So Onkar will start presenting. Wait at the end of presentation of the history. We'll have some discussion and then pass on to the examination and then go for discussion. Onkar, you can share your screen and start.
Good morning, sir, senior and my dear friends.
Good
morning, sir, seniors and my dear friends. I am Dr. Onkar Nath, second year DNV PGT, and I will present a case presentation on epigastric lump. My patient, 40-year-old gentleman, businessman by occupation, resident of Havra, Kolkata, came in OPD with chief complaint. With chief complaint of lump in the central part of the abdomen since 2 months. History of present illness. Patient was apparently well 3 months back when he experienced an acute epigastric pain. Pain was sudden in onset, colicky type, intermittent in nature. Started in the epigastric region, then radiated to whole of the abdomen and back, relieved on taking medication and bending forward, and exaggerated on taking food, associated with multiple episodes of vomiting and nausea. Patient was diagnosed with acute pancreatitis at private nursing home, for which he required hospitalization for 10 days. About 20 days following onset of pain, patient noticed a lump in his central part of the upper abdomen, which was initially of 2 into 2 centimeter size, then increasing in size for a duration of 1.5 months and has been static for the last 15 days to attain current size of 5 into 5 centimeter, associated with intermittent dull aching pain for the last 3 weeks, which relieved on medication. There is no history of any abdominal trauma. There is no any other systemic symptoms. Past history. There is no patient is not a non-diabetic hypertensive hypothyroid. There is no history of tuberculosis, COPD. There is no any past surgical history. Personal history. Patient is married, has 1 son and 1 daughter. Consume mixed diet. His bowel and bladder habit is normal and is non-alcoholic. There is no any family history. There is no significant family history. Treatment history. Patient was managed conservatively for acute pancreatitis 3 months back in private nursing home. Allergy history. There is no known allergy to any drug or diet. Summary. 40-year-old gentleman presented with the lump in central part of the upper abdomen for last 2 months. Lump was initially of 2 into 2 centimeter in size, which gradually increasing to attain current size of 5 into 5 centimeter. It is associated with dull aching pain for last 2 weeks, which is relieved on medication. Patient has history of acute attack of pancreatitis 3 months back, for which he was managed conservatively in private nursing home. Bowel and bladder habits are normal. There is no any other systemic symptoms.
Okay, Dr. Bhomik, go back to the First slide. We
Yes,
can have
sir.
some discussion on his presentation.
Yes, sir.
Yeah.
So, Dr. Omkar, what would be your differential diagnosis from the chief complaints that you have mentioned?
Sir, pseudocyst pancreas, hydrated cyst of the liver, hydrated cyst of pancreas, cyst is mesenteric cyst, sir.
Okay. Any other differential diagnosis? Mesenteric cyst in this location, is it a common location for a mesenteric
No,
cyst?
sir. No, sir.
Okay. Considering the patient's age, you would what would be your TD?
Pseudocyst pancreas, hydrated cyst of liver.
I mean, would you want to go think towards a benign etiology or a malignant etiology?
Benign etiology.
Okay. And then next slide. So, what do you think is the etiology for this pancreatitis episode of pancreatitis that he had? What do you think is the etiology
Sir,
for it?
alcohol, sir. Alcoholic.
Alcohol.
Yes.
Achha, but you have you mentioned in detail in the history about alcohol intake? I didn't find that in the summary also.
He has just
No, sir.
mentioned chronic alcoholic. That is not enough. You see, you are going through the history. The history is very important. Whether this acute pain was preceded by a binge of alcohol, that is one. Patient may be alcohol taker, but he may have other causes of this acute onset of pain. Patient with alcohol may have history of pain because of peptic ulcer disease, maybe because of pain because of a biliary colic. You say it's a colicky pain.
Yes.
So you have to make out whether this is a situation of just an acute episode of pain, not preceded by any other history of pain, or it can be a situation that patient has got history of repeated attacks of pain earlier, and then this time this pain has aggravated. Because the importance in pseudocyst diagnosis, you have to make out whether it is a pseudocyst following an attack of acute pancreatitis, or it is a pseudocyst having a patient with chronic pancreatitis. Okay, that history is important, because in the history you have to exclude whether he has got any evidence of chronic pancreatitis. What you have asked to ascertain whether he has got any other features of chronic pancreatitis. You have not mentioned anything. This is a history of the pain. Next.
So, and also you have mentioned colicky pain in your in the nature of pain that you have mentioned. You have mentioned that it is colicky. Is it usually colicky, the type of pain in acute pancreatitis?
Sorry.
So does that point to some other etiology?
Sir, colicky pain will be in the if there will be luminal structure which is tried to
patient having an acute pancreatitis
Yes.
preceded by a colicky pain. Preceded by a colicky pain.
Yes.
What it can be then? What are the common causes of acute pancreatitis?
Gallstone pancreatitis.
That is one. In this part of the country, gallstone is more common than alcohol.
Yes.
And next is alcohol. So Dr. Bhumik is asking, if the patient has got a bout of alcohol and he has sudden pain, is that pain like a colicky pain of CBD stone or gallstone?
Yes, sir.
Usually not. Patient may have a dull aching pain, and this pain can aggravate. Colicky pain is a pain which has got waxing and waning.
Yes.
And then I ask you, what in the history of asked to ascertain whether the patient has got a disease of chronic pancreatitis? What can be the other symptoms?
History of binge alcohol intake.
Binge alcohol can precipitate one attack of pancreatitis, but patient with chronic alcoholic, which is consuming alcohol over a period of time, may have the episode of developing chronic pancreatitis. What are the other triad of presentation of chronic pancreatitis? Triad of presentation of chronic pancreatitis.
Pain,
Pain is one. Second,
vomiting,
not
nausea and
vomiting.
vomiting.
No, triad is three important criteria to diagnose chronic pancreatitis.
Yes,
one is pain.
Pain and
Second is malabsorption.
Malabsorption.
And third is
Sir, on examination,
no diabetes. So patient having chronic pancreatitis may present either with pain or may present with pain plus malabsorption because of chronic exocrine insufficiency, and may present with diabetes because of endocrine deficiency. So my history should touch that point, because the management will be different in a patient who has got acute pancreatitis with pseudocyst or patient with chronic pancreatitis with pseudocyst. Next. So you asked about the pain. Yes, Dr. Bhumi.
Also, sir, I think the first acute episode should have been described in a bit more detail when it is relating to the. What do you think?
Yes. Whether this episode of pain was started following a binge of alcohol, that points more towards alcohol-induced pancreatitis, or patient has a history of colic, which is mimicking like a biliary colic, and then the colic has been replaced by a dilating constant continuous pain, which may aggravate, may lead to the back when the pancreatic inflammation starts. So that history is important. How is the onset of this episode of pain? He said you studied the lump, but it's good that you studied the pain history, because this patient presenting the lump has got an important history 3 months back. So 3 months cannot go to past history. That will remain in the history of presentativeness. That is good. But you have to give a detail of the history of pain with which is admitted. In fact, the history will start with that only. And then, as Dr. Bhumika was asking, we will not be confined only to the pseudocyst of pancreas. As a patient presenting with a lump in the central abdomen, you have given the history. So history was acute pain, then swelling. So there will be something related to the pancreatic pathology here, because history of acute pancreatitis can lead to cirrhosis of pancreas. What else in the pancreatic pathology can have similar presentation? Maybe a pain, may have got a cystic swelling in the epigastrium. Other pathology in the pancreas?
Cystidinium carcinoma.
Yes, cystic neoplasm.
Cystic
neoplasm in the pancreas.
Yes.
Okay. Before you think of other diseases, you should think of intrinsic disease in the pancreas, because the epigastric lump. Can it be a lump arising in the stomach? Such a lump in the stomach, what other symptom you expect? You expect early satiety, nausea, vomiting. And in the history, again, you have to ask some questions to find out whether this pseudocyst is having a complication. This pseudocyst may be just a swelling itself. Apart from this pseudocyst can produce some other symptoms because of its presence. What else you should have asked?
Sir, history of fever.
Not fever. Fever is afterwards. Before that, mechanical effect. This pseudocyst can cause compression of the stomach, causing gastric obstruction. Can cause duodenal compression. Because in the history, you have to exclude that. Patient has no sensation of fullness after meals. Patient has no vomiting. So these exclude that patient does not have a gastric outlet obstruction. Second is this cirrhosis can compress the bile duct, or the underlying chronic pancreatitis can compress the bile duct. You have not mentioned whether the patient has got any history of jaundice. You are saying there is no history of jaundice, means I can assume that there is no compression of the bile duct. So history is not just saying about few lines about the pain and the lump itself. You have to ask other symptoms, so that you see, once you say no vomiting, no fullness after meals, no jaundice, I assume that this pseudocyst is not compressing the stomach outlet. This pseudocyst is not compressing the underlying bile duct. And then this cyst may have other complications. But with a persistent cyst, these other complications are usually not very common. In that case, cyst may suddenly disappear. That is a different situation. And then you should ask about other symptoms to exclude other associated disease. So you make a habit that once you're in the abdominal case, you ask about all other abdominal symptoms. Okay, appetite, weight loss. It can be a cyst adenocarcinoma in the pancreas. So you should ask about other general symptoms pertaining to the GI system. So all the symptoms should come to the history. It's an exhaustive account of all the symptoms patient may have who is present with the lump in the epigastrium. Dr. Bhumik, any other point?
Have you mentioned relation to food intake?
Sir,
I mean, I
lump.
didn't find.
Sir, earlier, sir, pain increases on food intake, sir.
Earlier means?
Like when patient was presenting with the pain 3 months back, then it aggravate on.
What Dr. Bhumik is asking, now you are saying he's having dull aching pain. Is this pain related to the meals?
No, sir.
That is important.
Either this one or even the previous episode, or whether he had multiple recurrent episodes which didn't require hospitalization or admission. And you have mentioned size of the lump. I mean, had the patient mentioned about the size himself, or you made it out yourself?
Yes, sir, we mentioned, sir. I asked the patient about the size of the.
Okay. So we can proceed, I think.
Yeah, actually, this lump size distribution is now we are relying on the patient gesture. As gestured by the patient, he's saying the lump was like this. But you see, getting a 2 cm lump palpable by the patient is very unusual. You see, a 2 cm lump in the abdomen patient can appreciate is a very difficult situation. It will be a little more because 2 centimeter is just a 2-finger breadth. That is difficult for the patient to appreciate that the patient having a pseudocyst following acute pancreatitis is not 2 centimeter at the beginning. It can be acute fluid collection with a sensation of fullness, and then he appreciates the lump. So always keep in mind that for a patient to appreciate something in the abdomen itself, it should be a little bigger. It cannot be just a 2 centimeter lump. Okay, so apart from the lump, apart from the pain, take other history pertaining to the GI system, which will exclude other associated symptoms, any symptoms of complication. And you can make out some underlying causes which can cause pancreatitis. Come to the personal history about the alcohol. Yes, you see, addiction, alcoholic does not mean anything. What do you mean by alcoholic addiction? You are stamping the patient is alcoholic addict. What does it mean? I am sure with onset of pain and this lump, he is not drinking now. Is he drinking?
No, he's not.
Then you have to give details. This detailed history of alcohol is important because what do you mean by addiction? Just define addiction. You're saying he's alcohol addict, somebody's addicted to smoking. What does it mean? What? Before dependence? You see, once you say something, you must understand the meaning of that word. What do you mean by addiction? Addiction is when the patient is consuming some substance for a reasonable period of time. You take 1 day alcohol, next morning you cannot be addicted. So somebody consuming some substance for a reasonable period of time, number one. And next is, if he is a chronic alcoholic, for the same effect, he need to increase the dose. And he's alcoholic and he's addict. Other criteria to say is, he cannot go without it. That means he has a craving for that particular substance. Consumption for a period of time, craving for the particular substance. Okay, he want to get it at any cost. Next is, if he is denied the substance, he will have some symptoms we call as withdrawal symptoms. So if you have these criteria being present, then only somebody says he takes alcohol once in 6 months during some occasion days, he go without it, he cannot stamp his alcoholic. He can be an occasional drinker. So once you write alcoholic and a patient with pseudocyst, chronic pancreatitis, this history should be more elaborate. What age he started drinking, what is the average ounce he is drinking, what is the frequency, whether he is still drinking. Okay, so that is important. You cannot just write one word for a patient having a pancreatic pathology regarding alcohol. Okay, next. So you can pass on the examination.
Yes, sir.
Yeah.
General survey. Patient was examined in a well-lit room after proper consent. Patient is alert, conscious, cooperative, average wilt, and Karnofsky performance score is 90. Vitals. Blood pressure is 130 by 80 millimeter of mercury in right upper limb in supine position. Pulse rate is 86 beats per minute, regular and within normal volume. Respiratory rate is 18 per minute, regular and abdominal thoracic in nature. Patient is afebrile in nature. Patient is afebrile. There is no pallor, icterus, cyanosis, clubbing, and lymphadenopathy. There is no engorged lymph in neck veins. On abdominal examination, on inspection, abdomen is normal in shape. Fullness is present in the epigastric region. Umbilicus is in midline and inverted. Skin over the abdomen is normal. No any pigmentation or engorged vein. All quadrants are moving normally with respiration, and there is no any visible peristalsis. The lump of 5 into 5 centimeter noted in the epigastric region, which is globular in shape, has well-defined margin. Surface is smooth and not moving with respiration. No other swelling noted in the abdomen. On palpation, temperature is normal. No any tenderness. And a firm non-tender lump is palpated in the epigastric region within 6 into 6 centimeter in size, globular in shape, with well-defined margin, has a smooth surface, with all borders palpable, not moving up and down with respiration, and non-mobile. No any other swelling palpable in abdomen, and there is no organomegaly. Systemic symptoms. Respiratory system, palatal vesicular breath sound heard, and cardiovascular system, S1, S2 heard, and on CNS examination, there is no focal neurological deficit present.
Go back to the no, this general survey. Karnofsky 90. What do you mean by Karnofsky 90? You said Karnofsky performance study is 90. What does it mean?
The patient is able to do all his work normally, but mild symptoms.
Mild symptoms. What do you think? This patient having a episode of acute pancreatitis, he is having a lump, he is having pain. Do you think this is a presentation with a minor symptoms? It is not. Even 80 patient will be able to do normal activities with effort. And he has got major symptoms. I will not consider this presentation of a lump, pain as minor symptoms. So it will be safe to write Karnofsky as 80. Okay. Momik, any question regarding his general examination?
Yes. So you haven't mentioned about nourishment, I find. Is there any importance of assessing nutrition? Because your patient has a GI pathology, he is not eating well.
Yes.
I think he is not eating well. You told about early satiety and all.
Sir, there could be the history of weight loss and build.
How it is important in your patient?
How can build change acutely? Acutely, what can change is nutrition. No? Build is
will be, sir.
Is build and nutrition same? Is build and nutrition same?
Nutrition status.
Onkar, even a DNB exam is a upgraded MBBS examination. Okay, so you cannot just confuse these minor things also. Build is what? Build is a skeletal framework, the stature of the patient. So that is not dependent on nutrition. Build is the stature of the patient. He may be 5 feet 6 inches, maybe 5 feet 2 inches. So that depends on the race, sex, everything. This build is determined. How do you assess nutrition? This is very important in this patient. What are the ways that you say patient is nutritionally preserved or nutrition is poor? BMI is a objective assessment. Before that, there are some clinical markers of malnutrition. Clinical markers of malnutrition.
Sir, yes, sir. The patient will be cachexic.
So first is the general appearance.
Appearance.
If you look at the patient, you find he has got malar prominence, he has got vestigial muscles, he has got loss of, so general appearance may be a pointer to his malnutrition. But sometimes general appearance may not look that bad. In malnutrition, general may not be that bad. But general appearance, if the patient is grossly malnourished, you can make out. So what is general appearance? What else? What are the other ways to assess nutritional status? This is MBBS question.
Calorie.
क्या calorie क्या पता चला? You are examining the patient. What do you see? Tricep skin fold thickness.
Tricep skin fold thickness.
What does it indicate? Once you do a tricep skin fold thickness, what is the implication? In a normal patient, there is some fat underneath. So patient is malnourished, may not have fat. Just you pinch the skin. Then mid-arm circumference. What does it indicate? What does it measure? Bulk of the muscle. Bulk of the muscle. That indicates the protein status in the body. Okay. And then come to the BMI. How do you calculate BMI? You have not mentioned about BMI here. What is BMI?
So, weight in kg upon height in meter square.
Yes. And then you have to specifically mention patient who has got gross malnutrition will have some evidence of micronutrient deficiency. What is that? How will you make out micronutrient deficiency?
Sir, I will ask sir, take history of sir any oral symptoms
like
sir, ulceration, oral ulcer, cheilitis,
angular stomatitis, and look at the tongue to look for smooth tongue or red tongue. You ask the patient whether it's got any difficulty in vision at night. Night blindness can occur in vitamin A deficiency. Patient may have dryness of eyes, xerophthalmia. So these are all important. You see, these may be an MBBS question. But if some examiner goes on to you to just talk about nutrition, these are all very important. So you must be knowing how to assess nutritional status in a surgical patient. One is general appearance. Next is tricep skin fold thickness. Next is the muscle bulk be estimated by mid-arm circumference. And then go for micronutrient deficiency. Okay, vitamin, another micronutrient deficiency, and the BMI. These are all important. So next.
Also, have you mentioned about any signs of dehydration, the condition of the skin and all?
I have not mentioned.
These are all important.
Yes.
Hydration status. You see, few things in a major surgical case, particularly patient having malignancy, and patient has some GI symptoms in the form of vomiting. These are all very important. Karnofsky's performance status, hydration status, and nutritional status. How is nutritional status important, particularly in this patient? This patient has come to surgical ward. He is admitted for surgery. So you have something in mind to do surgery in this patient. So how nutrition is going to affect your outcome in this patient?
Sir, if nutrition status will be poor, then it affect wound healing after surgery.
What nutritional status?
After
what nutrition is important? Then next question will be some investigation also. So what particularly nutritional status will be reflected, which can affect your outcome?
Sir, albumin level.
Albumin level. So albumin deficiency indicates a global nutritional deficit. It's not that albumin is deficient. Albumin level deficient means you have to consider patient has got other nutrient deficiency also. So it's not that you give the patient albumin transfusion and take him for surgery. In that case, you have to build this patient up. Otherwise, if you don't build up the patient, if you are doing some anastomosis, that may not take, that may leak. Okay, come to abdominal examination. It's a virtual case, but you cannot say whatever you like. It's a virtual case, I understand, but patient has got a 6 centimeter lump in the abdomen. Is quite a large lump. And if you say, I am finding the lump in the epigastrium, you will fail in the exam, because patient will be lying in front of the examiner. The epigastric region is ending where? At which plane? Transpyloric plane. That means you put your hand in the differential junction, and that is the area where epigastric ends. Large area in above the umbilicus is umbilical region. So if a 6 centimeter lump, it cannot be confined to the, I will not accept it at all. If the patient is sitting in front of me, I'll ask you to palpate. So you should always keep in mind, when you describe an abdominal lump, these are very important. There are some steps to describe the abdominal lump. Dr. Bhumi, you can ask about this lump.
What is the importance of mentioning that umbilicus is in midline and inverted?
Sir, if a lump will be more bigger in size, then it will push the umbilicus and
do you think a 6 centimeter lump will not
sir,
push the
this
umbilicus down? Because a patient is not there with me. If you say patient has got a 6 centimeter lump and you measure the distance between the differential junction to the symphysis pubis, it cannot be in the center and midline. The umbilicus has to be pushed. So keep in mind, these are all important. You cannot go as stereotype. The patient is in front of you.
Sorry, sir. Also, if you find that if you find that the umbilicus is everted, do you suspect anything else also except in relation to the lung?
Yes, sir. Ascites, there could be presence of ascites.
Okay.
And you are saying such nice description inspection, which is not possible. If you have a lump in the epigastrium and umbilical region, which is like a pseudocyst, it is very difficult to make out on inspection that lump has got a nice border. It's not possible. Because on inspection said there is fullness in the epigastrium. And sometimes lump of maybe 4 centimeter, 5 centimeter, it may not be seen on inspection. You may not make out the borders. So if at all you can make out the border, it is difficult to say has got well-defined margin on inspection. That you cannot see. You see, if you look at the patient abdomen, you will find there is fullness and there appears to be swelling. And particularly if the swelling is not moving with respiration, it is more difficult to make out the borders. So don't go with the classic description in some other case somebody has presented. You have to confine to the particular patient you are presenting, and examiner will be in front of you. If you fail in the clinical part, you will fail in the examination. The clinical part is very important. You should stick to what you are looking at and describe. As I said, a 6 centimeter lump cannot be confined only to the epigastric region. It has to come to the umbilical region.
Also, sir, when a lump is retroperitoneal, it's difficult to have a well-defined margin.
And you have not given the description. The lump is intraperitoneal or intraabdominal. What is that? How do you make out? This lump is there in the epigastric region. The first thing to make out in this lump is to say whether the lump is intraabdominal or parietal. And then don't go for knee elbow position. Don't ask the patient to make knee elbow to find out is it intraperitoneal or retroperitoneal. That is not required.
Leg raising test.
Leg raising test. What will happen? Have you done this? That is important. This lump in the epigastrium may be a desmoid tumor. Maybe a tumor arranging with the abdominal wall itself. So to say this is the intra-abdominal lump, the first thing is a leg rising test or head rising test with the upper abdominal lump. So say, comment that is an intra-abdominal lump located in this region, and dimension, if you are not finding that the margins are seen at all, don't comment about the lump size on inspection. You can do it on palpation. You can say there is a fullness, but the margins of this lump cannot be. If you cannot make out the margin of the lump, how can you say the size? You cannot say the size. Okay, next. Next. Yes. You said no other organomegaly. What other organomegaly you have tried to appreciate here?
Hepatomegaly is
Hepatomegaly is one. What else?
splenomegaly.
Why this patient may have splenomegaly? And if the patient has got splenomegaly, what is the implication? What else you should look for now? Patient having a pancreatic pathology and patient has got splenomegaly. What is the implication? What patient may have?
Sorry.
This patient may have associated portal hypertension. Okay, patient having a pancreatic pathology can cause splenic vein thrombosis, which can cause splenomegaly. Patient may, because again, this is another complicated situation. You should keep in mind the patient who has got a pseudocyst and has got a portal hypertension. You need to do some more evaluation, and that has to be considered during the management of the patient. Okay, you have not in any surgical patient, even if you don't doing it, you have to write parietal examination. You have not mentioned that. That is important. Parietal examination has to be mentioned. Okay. Have you tried to palpate the gallbladder?
Gallbladder was no.
Gallbladder not. Yes, but that also should be when you talk about organomegaly here. Even patient having a gallstone pancreatitis may have a palpable gallbladder, although that is not very common. But you should be very specific about what you're trying to say about no organomegaly. Next, what about percussion? You have not done that. So next, you cannot skip. You see, after palpation, go to system examination. Why? As Dr. Bhumika was asking, patient may have ascites. Okay, you have to comment about the lump, whether this lump is resonant or this lump is dull. So percussion should be a heading.
Also, whether
should be heading.
also whether you could insinuate your fingers between the lump and the costal margins to make out the borders, like you have mentioned the size. So that also I think you should mention.
Was it possible to palpate the upper border of the lump on palpation?
It will be difficult.
Then what you have mentioned, because go back. When you are palpating, was it possible to palpate the upper border of the lump? Palpation. Yes.
All.
So if you say you can palpate the upper border, sometime if the lump is bigger, you may not be able to palpate the lower border, upper border. And what Dr. Bhumika is asking, if you're seeing a not upper border, one differentiation between the liver enlargement and non-liver is it will be possible to insert the finger between the swelling and the costal margin. If it is a liver enlargement and liver swelling, you may not be able to do that. Okay. So, what's your provisional diagnosis?
40-year-old male presenting with a lump in the central part of the upper abdomen, most likely to be a case, most likely the case of pseudocyst pancreas.
As a sequelae of?
The sequelae of alcoholic gallstone pancreatitis.
Gallstone.
In this case.
What do we find?
Colicky type.
No, only colicky type pain will not give a diagnosis of gallstone pancreatitis. That's why I'm asking. If the pain has started following a binge of alcohol, it should be likely alcoholic pancreatitis. And if you have a history of pain for maybe 1 year, 2 years, 3 years, then it goes on the background of chronic pancreatitis. Otherwise, it can mean one episode of pancreatitis and this cirrhosis. Keep in mind what the patient you are presenting. Because patient presentation, patient profile is important to think about the management. Dr. Bhumik, you can continue from the diagnosis part.
So why do you think it is a pseudocyst of pancreas?
Justify the diagnosis.
Sir, first, patient was a diagnosed case of acute pancreatitis. Then patient presented with a lump in the abdomen, and patient was also non-alcoholic, and
No, except for a pseudocyst, it could have been a walled off necrosis or some other complication also, no? Why do you think it is not complicated otherwise and a pseudocyst?
Sir, there is no history of jaundice. So there is no history of jaundice. So obstructive symptom, obstructing cyst obstructing to
The
the
point is, you try to
CP.
understand what Dr. Bhumika is asking. You said pseudocyst. Okay.
Yes.
Now tell us what exactly you mean by pseudocyst.
Sir, it is the collection of the fluid lined by granulation of the fibrous tissues.
Yes. So if this collection occurs immediately after admission, patient is admitted with acute pain, and within 1 week you find there is a appearance of fluid collection, you can palpate some vague lump. Is it pseudocyst?
No,
What is that?
Acute pancreatic collections.
Acute fluid collection. You have to keep in mind Atlanta definitions. So that is acute fluid collection.
Yes.
Most of these resolves if this acute fluid collection persists and get walled off, it is pseudocyst. Dr. Bhumika has asked you a different question. This patient has got severe acute pancreatitis. And in CT scan, patient has got evidence of pancreatic necrosis. And you know, the necrosis is graded. Okay.
Yes.
Mild, moderate, severe.
Yes.
See, this patient has got a evidence of pancreatic necrosis. He is presenting with a lump in the epigastrium, maybe after 2, 3, 4, 6 weeks. What is that likely to be? Will it still be a pseudocyst?
Then in this case, sir, it will be sort of walled off necrosis.
Yes. So patient having such severe pancreatitis may have acute fluid collection around this pancreas. But patient has got associated pancreatic necrosis. And that necrosis will be graded depending on the CT finding. And this patient with pancreatic necrosis presented with a lump subsequently, we will not stamp that patient as acute pseudocyst. We will stamp that patient as probably he's having walled off necrosis. How you differentiate imaging? In imaging, suppose he's come with a lump now. On imaging, how can you differentiate that this is likely to be a acute pseudocyst or it's a walled off necrosis? What is the difference?
Sir, in case of walled off necrosis, there will be area of low area where it will take low contrast. So that area will be
cystic part will not take contrast. What you will see, there will be debris. There will be debris and there will be wall calcification. In pseudocyst, there is usually no debris. It's a fluid only. So if you have a lot of debris, internal liquors with the cyst is more likely to be a walled off necrosis. Okay. Next.
Achha, could you mention certain blood investigations that you would like to do, important blood investigations, and mention their importance in a line?
Ask him how this is your working diagnosis, and we discussed some differential diagnosis in this patient. How are you going to proceed with this patient? What should be your approach for this patient from this point on?
Sir, I will go for ultrasound of the abdomen, which is the continuation of the clinical examination.
What information you like to get by doing ultrasonography?
It will tell about the site of the cyst, whether it has any communication with the duct.
In ultrasound, you can make out. Don't jump. Ultrasound cannot give a diagnosis that this cyst is found in the duct. That is not possible. For this, you need some more investigation. Ultrasound can give a number of information.
Number of
one is the
number of
the nature of the swelling. Is it solid or cystic? If it is cystic, it is a clear anechoic cyst, or there is some internal echoes. As I said, internal echoes will indicate there is some debris inside. What else you look with the ultrasound?
So number of cysts, whether it is single
Okay.
or there is multiple cysts.
Next,
Mm.
next, you look at the pancreas. That is
Yes.
important. Either the cyst is sequelae of acute pancreatitis, or whether the patient has got the background of chronic pancreatitis. What do you find in pancreas if the patient has got a background of chronic pancreatitis? What do you find? Endocrine is how can you make out by ultrasound? Endocrine is blood test.
Yes. Sir,
What do you find the pancreas? The pancreas may appear atrophic.
shrunken.
Pancreatic duct,
It will be
chronic pancreatitis. What will happen to the pancreatic duct?
sir, it will be dilated.
And what else may be there in the lumen of the pancreatic duct in a chronic
That would
pancreatitis?
be presence of stones, sir.
Yes. So these are all you can pick up by doing ultrasonography. And the next part is biliarity, which needs evaluation by ultrasound. That is the best. For evaluation of biliarity for stone disease, ultrasound scores over CT scan. Okay, if you have a diagnosis of stone disease, the indication is ultrasound, not CT scan. So you look at the gallbladder, look at the bile duct, look for any stones. You see the liver. And if you have a suspicion of cyst adenoma, cystic neoplasm, in that case, you can find a mixed lesion in the pancreas. That is all important. So ultrasound, you said rightly, ultrasound is the best investigation for initial evaluation of the patient. That can give an idea what to do the next part. So ultrasound showed there is a cystic lesion in the body and tail of the pancreas with internal debris. Pancreas is normal, dark normal, biliarity normal. What next?
Then I will go for CACT whole abdomen.
CCT whole abdomen. Why?
To look,
Why do you need a CT scan?
sir, CT scan it will show the area of hypo decreased taking of contrast, sir. If area will be necrotic.
You see, if you have a cystic lesion, don't expect the cyst, the cavity of the cyst will take the contrast. What is more important for CT scan to tell you?
It will also
A patient having a cyst adenoma, this small solid component may be missed in ultrasonography. If it is a interductal mucinous neoplasm, that will be missed in ultrasonography. So CT scan gave a better delineation of the cyst, number one. CT scan can exclude a associated solid component. Okay. CT scan can see the pancreatic parenchyma better than ultrasonography. CT scan can show you the any extra vessels around the pancreas. As I said, patient may have with thrombosis with portal cavernoma. So CT scan you are doing with some purpose. And can CT scan make out cyst ductal communication?
yes.
Not always, difficult. CT scan, it is difficult to make out cyst ductal communication. Is it important to diagnose or identify cyst ductal communication, or it is immaterial?
Yes.
Why? Why it is important to ascertain whether it is a ductal communication or not?
To classify this for classification, sir.
For classification. Classification का फायदा क्या है?
So it will modify the diagnosis, treatment.
Yes. So to diagnose any associated cystic ductal communication, this will dictate our management also. Okay. So you've done a CT scan, cystic lesion, no solid component. Your clinical diagnosis corroborated. What else you like to do?
Sir, I will also like to do, sir, blood investigation, sir.
You have not been able to
MRCP,
ascertain
yes.
cease ductal
Sir,
communication.
ERCP, I will go for ERCP to
ERCP.
for MRCP.
So
MRCP.
don't pass on to invasive investigation. If you have the facility doing MRCP should be a rational investigation to assess cease ductal communication. Okay, so if you have suspicion of duct communication, you should do a MRCP. ERCP has got very specific indications. You don't do ERCP in all patients of pseudocyst because ERCP can aggravate the pancreatitis, can precipitate an acute attack of pancreatitis. Dr. Abhishek.
Yes, so you did an USG in the beginning. Do you want to add any modality to the USG that would help you in diagnosing something else which might be present in this patient?
Sorry, sir.
Anything else you add with the
Any modality you want to add to USG that would help you in diagnosing something else that might be present in this patient?
If you add a Doppler with this, any extra information you get? You can add Doppler while doing ultrasonography. How it can help you? Dr. Abhishek, you can answer. You can answer.
So it will help you in diagnosing a pseudoaneurysm, a relation of the vessels with the mass if it is present. If you are going for an operative planning, you need to know about that.
Okay. So you can make out any complications are there. Because if the patient has got a pseudoaneurysm, unless you address that, post-op patient can present with catastrophic hemorrhage. Okay, ultrasound can show you that, but for confirmation need a CCT. Okay, but ultrasound can give a guide. Ultrasound can measure the portal vein diameter. Ultrasound can show you the splenic vein. Ultrasound can show you the multiple venous channels around the pancreas.
Also, would you want to, what treatment would you want to provide to this patient? I mean, this specific patient.
I will go for, sir, cystogastrostomia.
If the patient refuses surgery, do you have any other option? Patient says, I will not do a surgical intervention on me. What are the other options? And now established options. Any other option apart from doing a open or laparoscopic surgical treatment?
Percutaneous drainage.
Percutaneous drainage. Any other option?
Endoscopic.
Yes. Now endoscopy is natural orifice surgery. Patient has no cut in the body. So you should always keep in mind that these are the more available options now, and it has got pros and cons, I agree. But if you are asked about what are the options, you should come out.
So
what are the limitations of percutaneous drainage? No, Dr. Bhumi, please.
There is high chance of recurrence.
Dr. Bhumi, yes.
No. I was just mentioning that. So you should mention that we can go for an endoscopic ultrasound, which can show us few things like relation of important vessels. If you are planning for an internal drainage, maybe if you are not sure about the diagnosis, you can aspirate and send for send for the biochemical markers like amylase and all. And also you can plan internal drainage. So that will help you.
What is the importance of analyzing the fluid? Suppose you're doing US and aspirate the fluid.
Yes.
How this fluid analysis can help you for diagnosis?
If amylase level, I will see for serum amylase level, sir. It will be elevated.
So, if elevated means what? It's a secret of pancreatitis. What else will do in the fluid being aspirated?
Sir, serum CEA and serum 99 level.
What is the implication?
Sir, it will indicate, sir, if it is elevated, then we can suspect, sir, neoplastic
Yes.
etiologies.
So if you have the facility for EUA and you have high suspicion of cystic neoplasm, you can aspirate the fluid and send for CA, CA125 and CA199. And elevation of this will give a diagnosis of cystic neoplasm, because in that case, the treatment is totally different. If it is a cystic neoplasm, treatment is resection. If it is a pseudocyst or older pancreatic necrosis, it should be a drainage. Okay. So we said percutaneous drainage. What is the advantage and what is the disadvantage of percutaneous drainage?
Advantage is, sir, it is very easy procedure,
Yes.
but it has a high chance of a recurrence.
Before that, recurrence will come afterwards. If you are doing percutaneous drainage, what can be the problems? You do just a blind percutaneous aspiration, or you will be doing some guided?
Sir, guided, ultrasound guided.
Ultrasound or CT guided aspiration.
CT guided.
So percutaneous, there are two things. One is percutaneous aspiration, and second is percutaneous aspiration and placement of pigtail. These are two different. It's a percutaneous aspiration drainage. You just aspirate and come out. In that case, you may require repeated aspiration. And second is you can put a aspiration and then followed by put a pigtail into the cavity. It's a minimally invasive procedure. You avoid a surgery. You avoid a major endoscopy procedure. What is the disadvantage?
High recurrence.
Huh?
High recurrence.
One is high recurrence. What else?
Sir,
One is recurrence. What else? You put a catheter, pigtail catheter.
infection.
Infection. What else? If the patient has got a ductal communication, what is going to happen?
Sir, fistula, it can
Yes.
lead to fistula formation.
It will lead to fistula formation. If there is no obstruction, this fistula may resolve. It can take long time for the fistula to get resolved. But these are the disadvantage of a percutaneous drainage. But tell me one indication when percutaneous drainage is acceptable. One indication where percutaneous drainage is still acceptable in spite of these problems. Patient has got a
pancreatic abscess.
This is the infected pseudocyst. Patient has got an infected pseudocyst. The wall is not mature. For doing internal drainage, you need a mature cyst wall. But patient has got a immature wall, patient has got infected pseudocyst, and you could demonstrate there is no ductal communication. You have done MRCP or ERCP, whatever, and find there is no ductal communication. In that case, percutaneous drainage may be an option. How is endoscopic drainage done? What is the technique of endoscopic drainage? Now this is coming up as a important modality of treatment, and some reports are there where it is said to be comparable or in some cases superior. Endoscopy claiming superior, surgeons are saying that surgery is superior. But there had been at least an acceptable alternative mode of treatment by endoscopic drainage. How is endoscopic drainage done? What is the technique? What they do?
Endoscope.
So you pass endoscope, you're in the stomach. Then you see, before you puncture the cyst, you should do an endoscopic ultrasonography, because this stomach and cyst wall should be opposing. If there is a gap, you puncture with the endoscope, you may not be able to puncture the cyst. Okay, so while doing endoscopic drainage, you add an endoscopic ultrasonography and see the cyst and the stomach wall is adherent, and then do an aspiration. Confirm that you can aspirate the cyst through the stomach wall. And then there are now provisions in the endoscope for using diathermy. And using diathermy, you divide the posterior of the stomach. But usually this is not like a surgical drainage. You do limited opening. But it is difficult to remove the debris because endoscope will be in the stomach. Okay. And then you just can do some lavage. It is difficult to do debridement in endoscopic drainage. That's what you can do in surgical treatment. And they claim there is good amount of resolution of this cyst following the endoscopic drainage. But what are the problems of endoscopic drainage? Problems of endoscopic drainage? You need a very expert endoscopist to do such procedure. The facility is limited. And number two,
it can aggravate pancreatitis.
It can
aggravate pancreatitis.
No. Why is aggravate pancreatitis? You're not going to the ampulla. You are going to the stomach. So the chance of relapse, the inadequate treatment is more with endoscopic drainage. So that is one of endoscopic treatment. What can be the alternative route of endoscopic treatment of pseudocyst? Another route for drainage of the cyst. If you have demonstrated there is a cystic and ductal communication, there is another way of endoscopic drainage known as transpapillary drainage. What is that? Transpapillary drainage. This is transgastric drainage. Another is transpapillary drainage. That means you do endoscopic sphincterotomy. Okay. If you do endoscopic sphincterotomy, ductal communication is there and this can drain. So there are two ways of endoscopic treatment. One is transmural drainage and one is transpapillary drainage. You said you will do cystogastrostomy. When will you consider doing a cystojejunostomy, not cystogastrostomy?
When size of the lump is more than 6 centimeters.
उसमें क्या फर्क पड़ता है? Lump size is not the only criteria for cystojejunostomy.
Persistently increasing size.
What will happen? If the lump is increasing in size, what is going to happen with this lump? Where will be the dependent part? You see, the pseudocysts can reach up to the pelvis. These pseudocysts are not always confined to this lesser sac area. When the pseudocyst is increasing, it can project to the lumbar region, can project lower down the retroperitoneum. So if the dependent part of the cyst is not in the stomach, then cystogastrostomy may not be adequate for drainage. Or cyst in the distal body and tail may not be attended to the stomach. You cannot do a cystogastrostomy. You have to do a cystojejunostomy. Tell me what may be the situation that swelling has suddenly disappeared. This often happens that patient admitted with the cyst and then after 1 or 2, 3 days you find cyst has disappeared.
There could be spontaneous ruptures.
One is how the cyst resolves. Tell me the ways how the cyst can resolve. One is just peritoneal resorption. Peritoneal resorption. Second is it can be free rupture in the peritoneal cavity. If it is a free rupture in the peritoneal cavity, patient may have features of peritoneal. Or it can be a spontaneous
resolution.
Spontaneous internal fistulization. It can rupture into the stomach. It can rupture into the duodenum or to the small gut or to the colon. Okay, so it can rupture into the internal organs and can resolve. Dr. Bhumik?
Yes, sir.
Covered the time. Any other question?
So I think we are fine.
The presentation is important. You have to keep in mind the proper presentation, proper description of the lump. That is important. Okay. Any question from anybody? Okay. Thank you. Deepak
Thank you,
is
sir.
Thank you.
Dr. Deepak is lecturer.